So when we set this up, we generally put a barrier on the handle in case I need to move this back or forth. We also put a barrier on the fiber clip so that if I need to move this fiber, we can move it, and then you're just touching the barrier. For a right-handed operator, we take the fiber and bring it out on the left side of the monitor looking at it. It's just the opposite on the other side if you're a left-handed operator. My assistant has already set up the first Explorer because I normally start on the upper left and I start on the lingual of the upper left. We've done the anesthesia already, and on the upper we typically use articaine and just infiltrate all the way around. In this case, we've just done the upper, the posterior of the upper left and the upper right. On the lower, since she's got some localized pocketing, we've also done infiltration on the buccal, and then we'll probably end up infiltrating through the papilla, because generally with articaine, on the upper it will penetrate all the way to the palatal, but on the lower it typically doesn't go all the way to the lingual. We also use, obviously you have to have a saliva ejector because there's water coming from both instruments, the ultrasonic and the endoscope. And what we use on the ends of these are soft stops. It's a product that's made by Smart Practice. There are other brands of these kind of things, but what we found is the soft stop works the best. You just put this on over the saliva ejector. It's also what I call a suction muffler because it kind of more evens the sound of the saliva ejector, which can be annoying. So when I bend this, and then the saliva ejector should extend a couple millimeters from the end of the saliva ejector. When I bend this, I bend it around my finger so that these two are parallel. The two tubes are parallel. Then I'll bend it a little bit this way and a little bit this way on one end so it looks like a snowshoe. When you're doing perioscopy, you should have the saliva ejector on the side that you're working on. And the reason why is because you don't want water constantly going over the tongue. The patient starts swallowing, and they keep swallowing, and by the third to the fifth swallow, they're going to cough. Okay, turn to the left, open real wide. Okay, I'm going to put the saliva ejector in there, and see how it just, you want it to passively rest just distal to the molar. Then we're going to use a bite block or a mouth prop. These are just styrofoam disposable ones. You can use different ones if you'd like. Some people actually use an isolite or that kind of a bite light type thing. Okay, open and go ahead and close on that. You okay like that? Uh-huh. Okay. So I got my ultrasonic. We use manually tuned ultrasonic. Again, I have my left foot running the ultrasonic. When we use these ultrasonics, when you hold the handle, here I'll turn this off for the moment. When you hold this handle, the cord tends to pull on you because the point of rotation is over here. If you bring the cord, what I call back around the back, the point of rotation goes here. It's much more ergonomic. With magnetostrictive ultrasonics, you do have an insert, and the insert can rotate. So what you want to do is you want to rotate it so that you don't have to turn it so much. If you have to turn it so much, then rotate the instrument. Okay, I'm going to lean you back a little bit more. Turn the saliva ejector on. Turn to the left. Normally what I do is tune the ultrasonic. Well, this is manually tuned. So what I want is I want the water to be swelling, and you can see that it is. When I turn the tuning knob and it's not swelling, it doesn't have as much power. So I want it swelling. I don't need to tune it so it's spraying. Okay, so what I do first generally is I do a tactile debridement. I go around with the ultrasonic. I'm removing plaque. In a heavy case with calculus, I'm removing calculus. you can see I'm using a mirror and there's no water spraying on the mirror. So that's why we like manual tuning. Automatic tuning, generally you have more water spray. A lot of times with piezo, the power is up way too high. So what I recommend is you just take the power on the piezo and turn it all the way down. You notice I turn the ultrasonic because I'm moving toward the other side. Starting to spray a little bit, so I'm going to tune it down a little bit. Okay, turn to this side. Okay, so I've done my tactile debridement. I'm going to pick up my first explorer, which is the left explorer. Turn to the left. So, since I don't have a mirror, sometimes I'll use the explorer and the ultrasonic to retract, like to move the cheek out of the way, for example, like this. So you don't need the mirror. You can hold the mirror and just bring it to the side and hold the explorer as well, but that's a little complicated at the beginning, so some people do that. And you want to position these petals so that they're comfortable. Okay, I'm going to look in the back of the mouth. I'm going to position this right at the distal lingual aspect of the second molar. I'm going to put my ultrasonic in there, and then I'm going to look at the screen. I'm going to turn the water on, turn the ultrasonic on. If I open the angle, I can't see anything because the water's rushing over the camera and it's not on the tooth. If I close the angle, I can now see the tooth. So I'll point out what we're looking at here. This is the shield, there's soft tissue, this is the distal lingual line angle, and I'm cleaning around the distal lingual line angle. I can go a little bit into the distal, but in this tooth it's really broad, so to see the distal, I'm going to need to use the angled explorer. Are you doing okay?
Uh-huh.
Okay, now I'm moving the explorer toward the palatal aspect. And I need to close that angle more. Okay, this water is not coming out. Oh, there we go. So I need to close the angle so I can see the tooth. And that's not unusual for shallow pockets. Okay, now I'm going into the mesial. You can see there's some plaque there. There's a crown margin right there. There's soft tissue. I'm going to go a little further into the mesial. And I'm moving the camera, I'm closing the angle and opening the angle, and this is what I call step wedging. Okay, turn a little more to the left. Now I'm going to look in the mouth, position this at the distal lingual of the first molar. You can see right there some calculus. This crown has a kind of an open margin. You can see there's the prep margin right there, and there's the margin of the crown. And it's pretty apparent from this endoscopic angle. And then the pocket's shallow, so the water's not getting to the tooth unless I have the ultrasonic in between. Now I'm bringing this around to the mesial aspect of the first molar. You see there's the crown margin, there's the tooth, the shield, and I'm going in sideways to clean the mesial aspect of the first molar from the lingual. Okay, so what I'm going to do is I'm going to change the explorer. So I'm going to have Katrina do this as well. But I'm going to show using the angled explorer. Okay, so I've changed the explorer. Now I'm going back to the distal of the second molar, and I put it in sideways, position my instrument, look at the screen. And now I'm seeing into the distal of the second molar. The temptation is to look in the mouth and then look at the screen like this while you're bent over. But when you look in the mouth, go ahead, look in the mouth, then sit up straight. And that concavity, I can't get the ultrasonic into that concavity like I want to, because it's not going forward enough. So what I'm going to do is I'm going to change this to the curved ultrasonic. Before I start going, I want to know my position is right, and then I want to check the tuning so that the water's swelling. Now I've done this for almost 15 years. I've taught it all over the world. I've probably treated well over 1,000 cases, cleaned well over 10,000 teeth. So for me, this is easy. At the beginning, it's not so easy. It takes a lot of coordination. It takes a lot of patience. If you don't have patience for this, then you're not the right person to do this. Because not everybody is going to be super good at first. It takes a lot of practice. But then again, learning all those hand instruments and doing it blindly, that takes a lot of practice too. And you still can't see what you're doing, and you never know when you're finished. In our practice, my perio practice, we hardly ever do surgery to treat periodontal disease. What I don't recommend is doing a lot of looking, just looking. You should be looking while you're cleaning. You'll notice that my feet are on the pedals, and I don't take them on and off. Go back and forth and on and off. That's too fatiguing, and it's not as efficient as just keeping your feet on the pedals. And you'll notice the saliva ejector has a nice even sound. That's because of the soft stop. You'll also notice that I don't have an assistant. My assistant is the saliva ejector. So what I'm going to do is put this back, and then we'll have Katrina go in and start things up. I'm going to take everything apart. The old system used to have a little handle here where you put this when you're not using it, but that's really inefficient. We just put the instruments on the tray where all your other instruments are. Okay, put the prop in. So you've got a really good view of the distal lingual aspect of the second molar. You can see in the lower right-hand side of the screen is the shield. Right in the middle to the left is a tooth, and the upper left quadrant is a gold crown. So yeah, just try to keep the ultrasonic in the visual field. and then you can see it's clean, so start moving. It's real important that patients are anesthetized. You know, I think we should be using local anesthetic for this, not topical anesthetic and not Oracix or the injectable topical anesthetic. It's just not good enough. Some patients obviously can tolerate quite a bit. Good, you're doing great. So you're kind of half feeling, not half feeling, but a little bit of feel, a lot of bit of looking. Okay, close that angle up. Good, keep coming around. Move a little bit now as you're looking. Good, close that angle. Keep moving. See, this is a real shallow pocket, so that the water's not hitting the tooth. If you put the ultrasonic in there, it may help to decant the water onto the tooth. So you're always looking through water. Okay, go to the mesiolingual line angle. There you go. Push that in there a little more. Push the tip in there. You always want to have the tip of the explorer on the tooth if you can, because that pushes the most amount of soft tissue out of the way. Close that. Close this angle a little. Yeah, good, good. Another reason we want to use local anesthetic is because you need to push the camera to the apical extent of the pocket. You want to make sure you get it all. What we know about blind scaling and root planing is that the apical limit is 4 to 5 millimeters as far as being effective. Anything past that, you're probably not going to be as effective without looking. So there are only two ways of visually accessing roots. One, open it up, or open debridement, and two, endoscopic debridement. So for example, if you look at medicine has cameras that pretty much go everywhere. And you wouldn't have your knee cut open if you could have it scoped. And most of us know someone, including ourselves, who have had either a shoulder or a knee endoscopically treated or arthroscopically treated, as it is for a joint. This is the only dental endoscope that you can do something with. There are other scopes, but they're basically really tiny endoscopic or intraoral cameras. This system has been proven for the last 15 plus years, and it's only been more refined to the point now where we have a much better image, a much more reliable system. The more toward the anterior you get, the more you can see on both sides of the tooth, the buccal and the lingual, with the straight explorers. The further back, the more difficult it is to see on the distal aspect, so you have to use the bent explorers, or the right and the left. Now you can see every once in a while you get these air bubbles coming up. And that's, ultrasonics creates cavitation, and cavitation is the creation of bubbles. So what I noticed is that magnetostrictive ultrasonics, because it's 25,000 cycles a second, doesn't create as many bubbles as piezo does. Piezo is typically 40,000 cycles per second, and you tend to get a lot more bubbles. So, close this angle, push it in, open it. Good. Keep going. So you can see she's not putting the ultrasonic down because she doesn't have to. She's just changing the Explorer, holding on to the ultrasonic. Again, she's holding the Explorer just like she's going to hold it to put the sheath fiber complex in. She's going to hold it the same way to unclip it. This is one thing I say a lot during the training is look in the mouth, position the instruments, look at the screen and clean. Then move around while you're cleaning. Having done my share of periodontal surgery, there's a lot more room for this little tiny camera and the ultrasonic than there is to try to flap it open. A lot more room. Especially on the lower lingual, it's much more difficult to flap access on the lower lingual with the tongue there. I read articles about how to use ultrasonics when you're not looking, and you're supposed to develop a pattern. You're not supposed to be just real random. But when you can see what you're doing, things aren't random at all. And you can see how your movements are a lot smaller. That tip of the ultrasonic the very tip is about 1/2 millimeter in diameter. Okay, now I'm going to go back to the distal. I've got the right, so I'm going to go to the distal. I normally go from the distal to the mesial, distal to mesial. Sometimes you can cross instrument, like I have the instrument coming in from the lingual now, the camera coming in from the buccal. Sometimes that works, sometimes it doesn't. A lot of times on the lower though, it works great. Okay, now I'm going to go to the upper right, so I'm bending this just the opposite way. Okay, open real wide, good, close, turn to the right. Good, so I'm going to do a tactile debridement. And I normally tune things in the mouth because you're working in the mouth. Why not doing it in the mouth? You don't have to go over there and do it. You're going to get a bunch of water in here anyway. At first, probably going to be doing maybe a quadrant at a time. Our hygienists are doing full mouths typically, all the time in 1.5 to 2 hours. Most hygienists, most practitioners are doing half mouths, and they're doing 1.5 to 2 hours for a half a mouth. Well, if you automate your procedure and you try to be as efficient as possible, switching explorers, and you have a method, and that's the method that we teach, you should be able to do this faster. This is how ultrasonics works. It's high levels of vibration that essentially crush things off or vibrate things off in the case of plaque. In the case of calculus, it just crushes it. We used to say, or we used to think, that pushing harder would dampen the vibrations and it wouldn't work as well, but these instruments are tuned to want to stay tuned. And so what we find is these pushing harder gives you more power, actually. Now certainly pushing harder with the tip can actually gouge the root. So that's why seeing is important. When you can't see, you have no idea what you're doing. And if you think your tactile sense is good, it may be good, but it's not that good. So what we say when you do perioscopy is you check your ego at the door. Okay, open, close. Now I'm going to switch to the left explorer. The left explorer is going to allow me to see the buccal and the mesial aspects on the upper right. Okay, turn up straight. I'm going to angle my ultrasonic so I don't have to fight with the handle. And make sure that this is all the way back there. When I'm doing it, I was just thinking, when I'm doing this, it's like I'm on a cooking show. You know, people are talking all the time. Oh, I'm chopping this, and I did this with my aunt and my uncle. You know. This is how we do it in the homeland in Italy. You know, It's funny. Probably the most common diagnostic thing we see is caries interproximally, especially on crown margins where you can't see them on the x-ray. Every once in a while I get a referral for a fracture rule out. So we'll anesthetize the patient, put the camera in there, clean, and see if there's a fracture. And sometimes it's fractured, sometimes it's not. Let me check that margin. Yeah, that's soft, so that's caries there. So we'll let her general dentist know that she has caries on the distal of number 4. It's interesting. I think we discount the need to know about and teach ultrasonics. The technology, okay, open, close. The technology of manually tuned magnetostrictive ultrasonics is from the late 50s. It's nothing new. Okay, so I'm going to go in with the left explorer because we're going to be looking at the mesial of number 19. That's where she's got a 4 millimeter measurement. And I just want to make sure that that's clean. So put it in from the buckle, position the instruments, look at the screen, and clean. Step wedging into the interproximal. Be able to smooth out a little bit. I'm going to cross instrument. And when I see myself come around the corner here, I know I've cleaned the entire mesial. That crown margin is not the best. What I'm doing is I'm pushing harder. That's removing that enamel that's part of that ledge. So what I've done is I've smoothed off that ledge just by pushing a little harder. Okay. Initially, this training is very much like learning how to use a dental mirror. You look in the mirror and you're just going, I don't know if my brain can get this. And then the next day, you're looking in the mirror again and you're going, oh yeah, okay. So what we know about these kinds of visual learning is that your brain needs a rest. That's why in our normal training, we do the didactics before the training, watching the videos. If you play video games, it's not a bad idea. If you learn how to use chopsticks with your non-dominant hand, that's not a bad idea. Just to kind of get you prepared for this, what you're going to be doing that day. Then we do the bench training and take you through the steps of looking at a screen, then getting into using both hands, and then you go clinically to use both hands and both feet. So the typical training, the day of training is bench training. We've already got the didactics out of the way. We see a patient in the morning, and then we have lunch, then we see two patients in the afternoon, and try to get some experience with all four quadrants and all four explorers. And then the big thing is just to practice. It takes about 10 cases, I would say, to become fairly familiar with what you're doing, setting things up, knowing how to position, looking at the screen, letting the screen govern your movements, thinking about whether you're comfortable or not. Then I would say after about 20 cases, you get to a pretty comfortable level and you start being proficient. You should start seeing amazing results as well. You made it. Okay, so afterwards, don't eat or drink anything until you can feel everything, because we don't want you to bite your cheeks. A lot of times if you're all numb on the lower, you could bite your lip, you could bite your tongue. So, just wait till you get all your feeling back before you eat anything. You can probably drink something because you can feel your lips, right? Mm-hmm. Okay. Afterwards, you may have a little tenderness in your gum. You may have a little bleeding. If you're not sure about anything, call us. Mm-hmm. We're going to give you some Aleve to take later, or an naproxen sodium to take later if you need to. Mm-hmm. That would be maybe about 3 or 4 o'clock. Mm-hmm. And just take it as needed. Mm-hmm. You're going to have some tenderness in your gum line when you brush and floss. Are you using a water pick? Mm-hmm. It might be a little bit tender using a water pick, but by tomorrow it's probably going to feel real normal. Mm-hmm. Okay?